That's fine.
Okay. Welcome to the 2025 PD Parlor with Dr. Priya Cardone. Dr. Priya Cardone's maiden name is Besagar?
Yep, that's right.
And she wanted everyone to know that she is a native Pittsburgher and graduated from Montour High School. A little fun fact.
Yeah, fun fact.
And thank you so much for continuing these PD Parlors into 2025. The topic today is cognition, which I believe is a series. This is the first of a three-part?
It's probably going to end up being 3 parts by the time we get all the information together. Yeah.
Okay. And please take it away, Dr. Cardone.
Okay. I'm going to share my screen. Nope, I'm not going to share my screen.
I think I need to give you privileges.
Okay. Okay. There we go. Okay. So, can everyone see my slide?
Yes.
Okay. And can you see that I moved to the next slide that says cognition part 1?
Yes.
Okay, perfect. All right. So I'm going to go ahead and start. So cognition is a huge topic. It's in the news. Dementia is in the news. Everyone is always conscious, and people are trying to be very conscious about risk factors and signs and symptoms of dementia to try to prevent them from developing that and try to reduce their risk factors. So I have this conversation multiple times a day. I thought this would be a very good topic, and especially to have it recorded so people can watch it later. Because the question people always have to me at the end of several visits is, am I going to get dementia from this? So before I can talk about dementia and how it affects Parkinson's disease specifically, I think it's very important to discuss cognition in the elderly in general, just regular age-related cognitive changes, because Parkinson's disease is a disease of the elderly, mostly people in their 60s and 70s. So you cannot ignore the fact that there may have already been cognitive changes that were just the natural and normal part of aging. So we need to know about those first before we get into any specifics. Okay, so what is cognition really? Cognition is a lot of things. It's your short and long-term memory. It's your visual spatial abilities, meaning being able to see what is in your visual field and process that information. It's language, communication. That means listening, interpreting, and being able to speak. It can involve numbers. It can involve language, pictures. A lot of different things can and are encompassed by cognition, as well as the ability to regulate bodily functions. So that also requires adequate cognition. Bowel bladder habits, swallowing, digestion, all of that is controlled in some part with cognition. You're having normal cognition. So then what is dementia? So there is no scan and there's no picture and no test that can diagnose dementia. Dementia is a clinical syndrome, meaning it is comprised of the patient's symptoms, the history that they discuss, physical exam findings, cognitive exam findings. So it is where you can have impairment of memory, impairment of visual spatial techniques and visual spatial awareness. You can have impairment of language and communication, and it will cause bodily dysfunction, physical changes. But there is no scan or no one test that proves someone has or does not have dementia. So an easy way to show you is this. This is a picture. This is a picture of a normal MRI of a brain. An MRI is a very clear and high quality picture of brain tissue. When someone gets an MRI, there are multiple different exposures that can tell you like what's happening acutely in the brain, what has happened in the past, what has happened in the past regarding areas where there may have been bleeding, areas where there may have been stroke. So this is the most common exposure basically that we look at that tells us a good general picture of overall brain health. So as you can see here, the brain tissue it's kind of fat and juicy and kind of plump. It's got all these little folds in it. That increases the surface area, meaning there's way more neurons in there. There's tons of little folds in here. That brain tissue stretches all the way basically to the skull, which is up here, this white outside of the skull. There's a little like supportive protective tissues, but basically the brain is almost all the way there, meaning it has not shrunken and there's no shrinkage of the brain. The other thing is all of these little creases and folds, those are the normal creases and folds. So this is a good size for how small that extra space should be in between the folds. And finally, these are the normal holes of the brain. They're called the ventricles, but basically that's where spinal fluid circulates in and around the brain, clearing away debris and bringing nutrients and oxygen and all the other stuff. And it cycles continuously. So these are the normal holes where that spinal fluid circulates. So a set of holes up here, set of holes back here, and another hole back here. Those are called the ventricles or sinuses. So this is a picture of a brain that has what we call white matter disease. White matter disease is basic. Oh, sorry, let me go back actually first. So the other thing I want you to notice here is on this brain, there are two different shades. So the outside looks white, which is, it looks white on the exposure, but in real life, the outside of the brain is gray and the inside of the brain is white. White means that there is a layer of insulation around every neuron. It's basically fat, so it's insulated. So you can think of it just like an electrical wire. Electrical wires are metal, and then they have rubber on the top. The rubber makes the signal stay inside the metal part, so it doesn't get lost out into the the outside of it. So same on the inside of the brain, all the neurons here are covered in this white fatty like a coating. So that is the white matter. So here, a healthy brain, you can see the difference between the outside gray matter and the inside. There's a clear line here. So that's good. On this brain, this is a brain that has what we call white matter disease, reminding you that the inside of a real actual brain in person is actually white because of that fatty insulative coating. So this brain, you can see the inside of this brain, there's a little bit loss of that gray white matter differentiation. So here where there should have been a very clear border, it's kind of getting a little smudged. And these little schmutzy white fluffy things all around are basically areas of tiny little brain injury that have occurred over and over again. Once you get a good amount of that brain injury, that is what contributes to a clinical syndrome of dementia. So we are going to go through all of the causes that contribute to this white schmutz, like white matter disease. So here's another kind of good picture. White matter disease. Again, outside is gray. Inside, these little white spots are all basically injured brain tissue that is just kind of injured. It's a little scar. It's left over. It never goes back to 100% normal, and it will never reverse back to looking like normal, healthy brain tissue. So this is kind of a mild amount. This is more like a moderate amount. And this is what we would say is a severe amount of white matter disease. The other thing you can see here, these holes and the natural folds in the brain, they're starting to look a little larger because the brain tissue is kind of shrinking down a little bit. So the natural holes and the gaps appear larger. It's kind of like if your brain is a grape, and then a grape turns into a raisin, it kind of gets shrunken down, shriveled, it loses some volume, and it gets to be like kind of some more of these little spaces on the outside. All right, and then the next thing that contributes to where like impaired functioning of the brain is what we call cerebral atrophy. And so atrophy is shrinkage of the brain. So you can see here, this is the edge of the brain tissue, but here's the skull up here. So there's kind of a bigger gap here than there was with this brain where it's pretty much touching the edge there. So this brain has shrunken a little bit. The spaces and the gaps have also increased in appearance because the tissue is shrinking. So these kind of spaces end up looking larger. You can see kind of black spots here where brain tissue is kind of just, it disintegrates basically, and it gets filled up with spinal fluid that just naturally takes up that extra space. Okay, so this is a list. This is what I could come up with over the past couple of weeks. It is not a complete list. It will never be a complete list, but these are the things that I try to educate patients about because these are the things that affect the brain. I loosely organized it into categories, but a lot of these things are, they overlap. So you can't exactly put everything in a specific category because there's a lot of overlap. So physical, measurable things that can affect the brain is high blood pressure, high blood sugar, and cholesterol, high cholesterol. Non-physical things, meaning not something that can be quantified or measured, depression, anxiety, attention deficit or hyperactivity disorder, medication side effects, or when you take a lot of medications, all of the side effects add together, or medications interact with each other and cause a different side effect. Psychiatric disease like bipolar disorder or schizophrenia. Chronic pain. Chronic pain weighs on the brain. One way I try to sometimes describe the brain is like a computer. It can only handle so many browsers at once. The more browsers you have open, the slower all of the browsers run. So pain is a browser, cognition is a browser. If you have a lot of pain that's taking up a lot of the brain's like energy, just like how like many browsers on a computer kind of take up the data, the processing speed, it slows all the other browsers down. Caregiver burnout. So a lot of times I notice patients who are taking care of other family members, their cognition sort of takes a little bit of a temporary downturn. It's due to stress and constantly taking care of other people's medical issues. That can also affect your own brain at some point. All right, so modifiable risk factors, things that a patient has control over. The three big ones are smoking, alcohol, and drugs. All of these are direct toxins to the brain, unfortunately. That's basically it. Sleep apnea or sleep disorder, again, modifiable, but not really always completely modifiable. You can treat sleep apnea, but if you've had it for decades, it likely has already caused some wear and tear on the brain. So if you have sleep apnea, it's important to try your best to treat it to reduce the effect that it has on your brain. There are other sleep disorders such as just insomnia, something called periodic limb movement disorder. So there's a lot of different sleep disorders that can affect your cognition as well, because sleep is the time when your brain basically cleans house. So the brain gets rid of debris, gets rid of extra proteins, kind of gets rid of garbage while you're sleeping, and not exactly during REM sleep, but during the other stages of sleep. So if you are not getting adequate restful sleep, which is separate from REM sleep, then your cognition will be impaired, because that's kind of when the proteins and the abnormal junk kind of builds up in the brain and does not get cleared out. Metabolic abnormalities, vitamins levels, iron levels, thyroid being too high or too low, all of these can cause cognitive changes. Hopefully temporary. If those are fixed back to normal, those changes should go back to their normal baseline. Exercise. So we actually know that cardiac exercise, cardiovascular exercise really does have an effect on reducing levels of dementia, because it promotes blood flow to the brain, and it promotes, again, garbage being removed from the brain. So the technical recommendation is 45 minutes 3 times per week of exercise where your heart rate is actually increased. Hearing loss and vision loss. So these are very important things to discuss, more recently being more aggressively treated. So hearing loss, if you cannot hear your environment, you will not cognitively participate as well as you should be, and you sort of become withdrawn. Vision loss, obviously, if you cannot see, and if you cannot see correctly, your visual input to the brain reduces, and that will cause a vague cognitive impairment as well. A lot of times, the hearing loss is a big one. So I have a lot of spouses telling me that they have to say things over and over again to their other spouse. And my question is that because they cannot hear you, or is it because they cannot understand you? So those are two major differences. If that spouse is not responding appropriately because they can't hear, that's an easy fix with a hearing aid or a hearing device. If they cannot hear, or they're not, responding appropriately because they cannot understand, that's a cognitive aspect. So yeah, it's important to differentiate those two. Reduced levels of social activity. So loneliness is a really big risk factor for poor cognitive health. Loneliness means you don't leave the house, you don't have a social group or a social network. That means you have less interaction with your brain, and that has actually been shown to increase levels of dementia. So I try to encourage my patients to maintain as healthy of a social life as possible, but it is difficult, especially in the aging population. If there are limitations with driving or limitations with ambulation, that's a significant risk factor. And diet. So we know that diets high in fat and processed sugars are unfortunately not good to the brain. As good as they taste, they are not as good for the brain as kind of what I generally recommend, like a Mediterranean type of a diet. So that's the modifiable things. The sort of non-modifiable risk factors is exposure history. So Pittsburgh is what we call in the Rust Belt. The Rust Belt is that industrial belt of the United States where there was a lot of industry, steel, coal factories. We do now suspect that those are all risk factors for developing Parkinson's disease because metal exposure can cause changes on the brain. There are specific metals that cause actual Parkinsonism, but in general, the metal particles, the fumes, the coal dust, all of those pollutants do affect the brain in a negative way and can cause that white matter changes on the brain. Genetics can't control your family history, unfortunately, but yes, many of the dementias I don't really find are truly genetic. It's likely a combination of all of these other risk factors that a person may have accumulated throughout their lifetime. Rarely is it truly a genetic form of dementia. But if that's the suspicion, that we can always send people for genetic testing. So cancer, chemotherapy, and radiation. Unfortunately, all three of these have effects on the brain. So cancer itself causes injury to brain cells. Chemotherapy basically kills cancer cells, but it doesn't always differentiate which are the cancer cells and which are just healthy, normal cells. So neurons are unfortunately quite susceptible to damage and injury from this. So there can be leftover injury from chemotherapy. And then radiation. So radiation, depending on the body part, can affect the brain, even if it is not radiation directly to the brain. So brain tumors or brain issues for which a patient may have received like stereotactic radiation or whole brain radiation, that will cause a kind of a global brain injury. However, radiation to the head, neck, or even the upper torso, like for people who have had breast cancer, no matter how focused those radiation waves were like focused, there you can only control so much. So once that wave bounces into the body, it will still bounce around and it will likely go a little bit to the head depending on the body part. Radiation to the head or neck also contributes to kind of a scar tissue building up on the carotid arteries, which are the two blood vessels that provide blood to the brain. So lots of radiation here causes like a crunchiness in these blood vessels that reduces blood flow to the brain, and that can cause that white matter disease or even actual strokes. Family history, sorry, that's the same as genetics. Level of education. So this one is tricky. Level of education does not imply or tell me about intelligence level. It just tells me what was the highest level of education that a patient pursued and was able to finish. So sort of the way to think about it is if you're starting kind of with your cup of your brain, like your reserve. So the higher your cup is full to start with, then the losses are kind of proportional to what were you starting with. So if you're starting with a very, very high level of education and functioning activity, a small drop may not be noticeable. A larger drop will be noticeable. If you are starting with a kind of a less full cup of a brain power reserve, a small drop may be more noticeable, but this is a highly variable and subjective risk factor. Autoimmune conditions. So autoimmune conditions also cause that white matter disease changes on the brain. Not really known what is the mechanism for that, but that is something that's checked. And many of my patients who have a autoimmune condition, they have little spots in their brains. Couple things I forgot to throw on here: migraine headaches. Migraine headaches can show up on an MRI. They can have a couple of little of those white spots, and that doesn't prove or disprove a history of migraines, but patients who have migraines are typically found to have a couple of those spots on their brain. So this will be an ever evolving and growing list. When I do this lecture next year, I'll update it. Okay, so, and more. So psychosocial stressors, a person's living situation, whether they have a safe and reliable living situation or are they moving around and it's an unsafe situation, that contributes to cognitive impairment, whether it's true impairment or sort of a pseudo perceived impairment. Parkinson's disease, of course. Parkinson's disease, we're going to talk about in the next couple of sessions more specifically. A patient's perceived level of symptom control. So a lot of times when patients are wearing off of their medications, they do feel a cognitive decline, like a wooziness. They're not thinking straight. There's a brain fog. And once their medications kick back in, they also feel cognitively a little bit back to being sharper. Seizures and epilepsy have an association with dementia, of course, because it's just stressors on the brain and abnormal electrical impulses on the brain. Okay, so we'll go through things one at a time. So the easy ones are the physical measurable parameters. So high blood pressure, diabetes, cholesterol, it's like the American trifecta, unfortunately. All of these cause white matter disease on the brain. The reason being, the brain is full of teeny tiny blood vessels that are extremely sensitive. They have to have exactly the right amount of sugar, exactly the right amount of pressure, oxygen, everything has to be very exact. Not a lot of room for wiggle in the brain. So whenever blood pressure is either too high or even too low, that can cause those little white spots. Too high, and then a blood vessel might kind of have a little tear or a little rupture, so small that you wouldn't see it unless a whole bunch of it occurs, and then it shows up as that white, fluffy, white matter change. Sudden drops in blood pressure also, because if you suddenly drop blood pressure and you are already maybe not getting enough blood to the brain because you have crunchy carotid arteries, that can actually cause what we call a watershed stroke. So it can actually cut off circulation and blood supply to a portion of the brain that actually shows up on an MRI, meaning that brain tissue has undergone a permanent injury. For Parkinson's disease, the fluctuations, highs and lows can cause a perceived cognitive brain fog, and that can occur in other conditions affecting the autonomic nervous system as well. So it's important to try to keep blood pressure in a narrow and normal range. Diabetes, so blood sugar. When the brain either has too much blood sugar or not enough blood sugar, again, injury to those little brain cells that depend on a very narrow window of normal blood sugar. Cholesterol causes, again, kind of a crunchiness, buildup of cholesterol plaques in the blood vessels. That reduces the amount of smooth blood flow back and forth to the brain. Also, cholesterol can cause little crunchiness of the blood vessels all the way inside the brain itself, again, contributing to those little injuries that show up as white matter disease. The physical things that are a little harder to measure or sort of more depend on the patient being able to participate well enough to test is vision and hearing loss. Hearing loss, if a patient ever endorses they have a little bit or even a question of hearing loss, it's just very easy to get an audiology referral and consultation, and it should just be documented and fixed if it's there. The vision loss, a little harder to quantify. Yes, you can go for a vision exam. However, it is harder to measure a patient's ability to process a visuospatial field. So you may have 20/20 vision to see things and read letters off a wall. However, your visuospatial perception may be impaired. So for an example, a patient being able to hold a key in their hand and insert it into a lock and turn it. That's a visuospatial task. You need to be able to hold the key, position the key correctly, position it to get into the lock. You need to know how far the lock is from you, turn it, and open the door. So that's kind of a process. So if your visuospatial awareness is impaired, that's something that can be affected. Another example is like cooking. So if cooking involves visuospatial perception, meaning you need to know where the pots and pans are, where's the knife, where are the ingredients, work all of it together, and that can be impaired, even if you have 20/20 vision exactly. Right, so metabolic's easy. If you're my patient, you know that once a year I check your B12, your ferritin, your iron, your thyroid levels, and your vitamin D levels. So B12, lower than 400, that's the standard, can cause neurological symptoms. So I always make sure people are above that level. Ferritin. So this is a newish one. So ferritin, if you've gotten your ferritin checked, you will see that even if you had a level in the teens, it's considered normal. That normal level is variable whether you go to UPMC, Quest, Allegheny, or another private lab. The new normal, as per hematology now, there has been a push lately to consider 50 as the new normal. So to give you a general range, an adult man should be somewhere in the 150s to 250s generally. A woman who's in her 20s and 30s having menstrual periods, they can drop as low as the teens to 20s or 30s. Somebody who has a bleeding issue where they have a issue where they're bleeding from the gut, for example, from cancer, they can be in the teens or 20s. So it's a huge range of what's normal. So some other guidelines: if a patient has restless leg syndrome that's affecting their sleep quality, and it's a woman, their ferritin should be around 50. A man should have a ferritin around 75. So these are the numbers basically, but the numbers are basically changing. So nowadays, I have my own goals, 30s to 40s. If someone's lower than that, I send people to hematology to determine why is that person's level so low and how can it be fixed. A common cause of low ferritin is heartburn, acid reflux, and acid reflux medication. So chronically having acid reflux can cause erosive changes in the stomach, impairing absorption of some of these vitamins. Then when you take acid reflux medication, the medicine itself reduces absorption of iron. So you're kind of hit both ways. So that's why it's important to know if that is the cause for a patient, because if that's the case, we have to skip the stomach altogether and figure out how to get iron into you a different way, which is usually the IV form. The oral iron also has a lot of side effects on constipation, which is already a problem for patients with Parkinson's disease, which can further increase their cognitive changes. So I like to skip stomach altogether and just get people's vitamins in through their blood. Thyroid. So hyper or hypothyroidism can cause a whole host of neurological symptoms: brain fog, fatigue, or even hyperness, nervousness. So that's something that has to be checked yearly. And the newest one is vitamin D. So all of us in the Northern Hemisphere have vitamin D deficiency, but more recently there have been more studies linking reduced levels of vitamin D to dementia. So I am now in the habit of checking once or twice per year for all of my patients, making sure everyone stays in a normal range. All right, and then blood sugar levels we talked about. Too high or too low can cause wear and tear on those little blood vessels that are just very sensitive. All right, so lifestyle, activity level, social activity, we discussed diet, sleep. So poor sleep hygiene contributes to not enough time for the brain to kind of reset, rest, and get rid of garbage. That contributes to reduced cognition during the day. Education level, we talked about. All right, the non-modifiable ones, again, we talked a little bit again. So metal particles, fumes, chemicals, household sprays, household cleaners. A lot of people who have hobbies such as woodworking, photography, and they develop their own film, working in a greenhouse. Any of these hobbies, you have to just make sure you're aware of any of these exposures and wear protective gear as much as you can. The cancer, chemotherapy, radiation we discussed. Sorry, I guess I must have discussed all of these, forgetting that I had slides on each one. Autoimmune disease. So there are a lot of neurological conditions that go along with an autoimmune condition. More and more information coming up about this nowadays. Autoimmune condition including lupus, psoriasis, eczema, myasthenia gravis, and any other of these autoimmune conditions, they can cause what we call dysautonomia, meaning abnormal automatic nervous system, which is what controls automatic body functions such as heart rate, blood pressure going up or down depending on what your body is doing. So when you have a disruption of that normal cycle, regulating blood flow and regulating blood distribution based on activity level, that can contribute to sort of the cognitive impairment, if it either directly by causing wear and tear on the brain due to too high or low blood pressure, or indirectly by causing like a fatigue and a brain fog due to cerebral dysregulation, basically. So it's important to know if that exists. And if it does exist, it's important to have an official workup and treat any actual underlying autoimmune condition before it causes actual organ damage. Okay, so the non-physical ones are hard. So depression and anxiety. We live in Pittsburgh. We get no sunlight here, basically, unfortunately. Recent political events, holidays, daylight savings time. So October to like February is like everybody's mood tanks a little bit. Depression meaning crying spells in the office, that's depression. That means that needs to be treated. Depression doesn't just mean, however, just like sitting and crying all day. It also means lack of interest in activities you previously enjoyed, lack of enthusiasm for going out or doing stuff that you previously would have had to do, or spouses saying, oh, I really have to push my husband and be like, we are going out. He never wants to go. I always have to push him out. That can be a sign of depression. Anhedonia, which is just kind of like a blah feeling where like you don't feel like doing anything. You kind of just have lack of motivation of wanting to do anything. Apathy, again, sort of in that same category where everything just feels kind of blah. So the reason why this is important is because depression and anxiety can cause psychomotor slowing. So psychomotor slowing, meaning slowing of the brain functioning, cognitive slowing, as well as the physical slowing down. So it's really important that that's treated, because if that is contributing to cognitive impairment, you will never be able to tell what is the underlying true cognitive impairment if there's a blanket of depression or anxiety on top of everything, because it clouds everything. So important that that gets treated and addressed. Anxiety. So I try not to always say the word anxiety, because people say I'm not anxious. Instead of saying anxiety, I say, like, do you spend a lot of time worrying about things that you should not be spending that much time or brain energy worrying about that specific topic? Or are you worrying about things that are out of your control and spending excessive amounts of time or energy worrying about it, even though you have no control and the amount of worrying you do will not change the outcome? So then people agree, yeah, okay, maybe I keep worrying. Or the other thing is, do you get worked up a lot about things that maybe shouldn't make you get so worked up about, without the ability to rationalize that whatever situation doesn't need you to get so worked up about, or doesn't require as much as your brain power or your energy? So if the answer to any of these questions is yes, then we address that and make sure that that is treated significantly so that it is not contributing to the cognitive picture. ADD and ADHD. These ones are biggies. In the patient population of people who have Parkinson's disease who are in their 60s and 70s, that means that when they were in elementary or middle school, maybe 50-ish years ago, ADD and ADHD were not evaluated for. So a child who may have had ADHD or ADD was just as like a troublemaker, or they just had to go sit in the corner, but they were not really evaluated as to why that could have been happening, because ADD or ADHD is a reduction of the attention span, and that can contribute to cognitive impairment, because your brain sort of has like kind of gaps where you've paid attention and you remember something, and then your brain stopped paying attention and you can have a gap, and then you paid attention and again you have a memory, and then you can have a gap. So it creates these gaps in the memory. So that can really be a major risk factor for reduced cognition. So I like to evaluate for that by sending people to the formal cognitive testing, because that they are able to tell, does this person maybe not have real cognitive impairment, they just have reduced attention span contributing. And if that's the case, we can either treat with medication, or more helpful is actually lifestyle modifications, which we'll talk about. All right, next is medication side effects. So every medicine we use for any medical problem has side effects. Any medication that is for the brain that goes into the central nervous system will likely have potential for cognitive side effects. That's just how the brain works. So just have to be cognizant and aware of that. So before we label someone as having cognitive impairment, we check, are there any medications here that are on board that are slowing down the brain function? Chronic pain. So we talked about your brain is like a computer with browsers. One of the browsers is pain. If pain is always up, it masks everything. So nothing has a chance to be normal if there is an element of pain. So pain has to be treated adequately. And whether that's from me or whether that's from pain management, all depends. But that is it's a risk factor, so it has to be treated. And then the caregiver burnout. So if patients are taking care of other family members, it can sort of weigh on the brain a little bit much. Symptoms sometimes cross over a little bit. There's kind of a phenomenon that I've noticed where one spouse taking care of their spouse who has Parkinson's, the non-Parkinson spouse sometimes starts to have a tremor or they have a little bit of walking problems. And I'm like, what's going on here? And it's usually it's just a weird thing that I've noticed. I don't know what to label that except for counseling them that I don't think you have Parkinson's disease unless I do. But if I don't really, I try to educate them and say it is hard to continue to see symptoms day in, day out, and then some of them don't come over to you. All right, so sleep. Sleep is where your brain cleans house. All the blood flow, all of the bad stuff, all of the toxins, the extra proteins get cleared out during sleep. So sleep is restorative. My big pet, like my peeve thing is sleep apnea. Sleep apnea is a huge risk factor for that wear and tear on the brain. As people get older, their chances of developing sleep apnea just increase. And reasons for that is, again, wear and tear on the brain, the parts of the brain that control the automatic function of breathing and maintaining muscle tone in the throat, that reduces as you get older. Muscle tone in the throat itself just goes down as you get older, contributing to some people saying like you have a hard time swallowing. That's the same thing that could cause sleep apnea. If your throat muscles kind of flop closed while you sleep, that impairs good blood flow. Even if you don't have actual apnea on the sleep test, you can have what we call oxygen desaturation, where for whatever reason, your heart and lungs are just not exchanging blood correctly, and you're not getting good oxygen levels into the blood. So it's even if blood is getting everywhere, and you're breathing good, it's just not good quality blood. So for either of those two issues, I typically refer people to pulmonology to establish care and decide what is the best treatment option. Pulmonology doctors are the ones who manage sleep disorders and abnormal breathing during sleep. REM behavior disorder. So this is a condition that's specific to Parkinson's disease. Basically, when you're in REM sleep, what is supposed to happen is that your body muscles are supposed to be paralyzed so that you do not act out your dreams and hurt yourself. In REM behavior disorder, this mechanism is impaired, so people act out their dreams, kicking, screaming, flailing, fighting someone. And this is dangerous for a couple of reasons. It can injure the patient, it can injure the bed partner, and it is just disruptive to like the normal sleep pattern. So this requires treatment either by medications, of Parkinson's disease medications at bedtime, or other medications, depending on what is this cause. Nocturia. So this is also a big one. Nocturia means how many times you get up overnight to go to the bathroom. The answer should be 2 or less always. More than 2 is not a good thing because that means it's disrupting your periods of sleep. So you're not getting long periods of sleep. And it's just disruptive. It also increases your risk of falling overnight. So when my patients admit to having this, if they're men, I send them to a urologist to discover what is the cause. It's usually a prostate issue, but Parkinson's disease itself causes bladder spasms, and that can contribute to the feeling of needing to get up and pee. So depending on what the cause is, we treat accordingly. If it's a female patient, I usually send them to urogynecology to do an exam, determine what other causes could be ongoing. And usually people benefit from some physical, pelvic floor physical therapy and or medications to reduce that nighttime need to get up to go to the bathroom. Restless leg syndrome. That's another one that's really bothersome to people being able to fall asleep and stay asleep. Typically contributed to by iron deficiency, so everyone gets checked for that. And if you just happen to have restless legs, not because of iron deficiency, we just treat that to make sure you are a little more comfortable and have easier time falling and staying asleep. Anxiety. So anxiety keeps people awake at night too. Anxiety hits at night when you're up during the day, you're busy, your mind is busy, occupied. You lay down to go to sleep at night, and some people cannot turn their brains off. And that's how I kind of present this to people. I don't say, do you have anxiety at night? What does that mean? It means, do you have a hard time turning your brain off and falling asleep? Or is your brain constantly running and thinking and you just keep going and going and you just can't shut down? So again, if that is a factor at play impeding sleep, we treat that. All right, so tests for cognitive impairment. Anybody who comes with cognitive impairment, after we gather all of that history, you get some tests. The MRI brain, as we talked about, shows me a generally very, very good picture of physical brain health. Is your brain shrinking a little bit? Is there any spots that are obvious old strokes? Are there spots where you have little bleeds or hemorrhagic bleeds from throughout your lifetime that's contributing to impaired cognition? If a patient has ever had a history of cancer, I always, as a rule of thumb, obtain an MRI with contrast because I always want to know, is there a chance that any cancer cells had migrated themselves into a patient's brain? Because that is extremely important. That changes the management drastically. Other than that, it's the blood tests that we talked about for the metabolic abnormalities. If they endorse hearing or vision loss or changes, we send for those appropriate tests. And finally, anyone who admits to snoring, poor sleep, waking up at night, generally restless sleep, or just feeling fatigued during the day, pretty much very, very low threshold for obtaining a home sleep test. And I will say probably 90% of the home sleep tests that I order come back positive, people having sleep apnea, even if it's mild. So even if you appear to have mild sleep apnea on the home test, I aggressively treat that because the home sleep test typically underestimates the true degree of apnea. So if it looks mild on the sleep test, you likely have mild to moderate, and any sleep apnea puts wear and tear on the brain. All right, so then the next step after that is formal cognitive testing. I do not send people for formal cognitive testing until I've worked them up for any of these risk factors that are affecting their cognition and fixed those risk factors, because I would like to give that patient the best chance of performing as close to what is normal as possible. If you have sleep apnea and you're not sleeping all night and you go to formal cognitive testing, it's just going to say you're tired, you're not paying attention because you have apnea. If you have severe anxiety, that will show up on the exam, where your ability to participate accurately and do a good cognitive test will be impaired. So that's not really helpful. So this only comes after all risk factors have been optimized, including mood symptoms. This is a couple of hours. So people will say, well, why can't you just do it in the office? It's too long. It's about 3 hours, I'll say. And the two people that I trust, or not just two people, there's a group that we use typically at UPMC. They kind of all have a very standardized format of how they do their testing. It delves way into a patient's past, any childhood issues, any issues throughout life, psychosocial stressors, brain injuries, major medical conditions, family history. So they put all of this together, and the testing involves testing of the short and long-term memory, visuospatial tasks, problem-solving skills, verbal attention span, a lot of stuff. So it takes a couple of hours. After those couple of hours, they put together a summary saying where they think a patient is in terms of their cognition. So that's very helpful for me. Couple more things that they are able to say. So cognition, typically it'll come back, what are your results? So you either have some form of cognitive impairment or some form of cognitive impairment that matches a specific named dementia. So if it is nothing named and it's just some degree of cognitive impairment, it will say either a mild cognitive impairment or MCI, moderate cognitive impairment, or moderate to severe cognitive impairment. And it will say either suggestive or not suggestive of a neurodegenerative disorder, or just severe cognitive impairment due to like risk factors and the wear and tear on the brain. The specific named dementias, the big ones are Alzheimer's dementia, frontotemporal dementia, primary progressive aphasia, dementia with Lewy body, and Parkinson's disease dementia. Those are kind of the main ones. So if you fit into a specific category, they'll be able to usually pinpoint that during this visit. And usually my suspicion of what I suspect in the office, and then if I suspect a named dementia, the formal cognitive testing folks usually also tend to agree, even though I don't tell them anything beforehand. So it's kind of like two people separately, independently thinking the same thing. That's kind of a higher likelihood of that being correct. A lot of these also overlap. So Parkinson's disease, dementia is a spectrum. Primary progressive aphasia and frontotemporal dementia are on a spectrum, we think. This is all new information in the last couple of years. It's now suspected that those are on a spectrum. So if you've heard of Bruce Willis lately in the news being diagnosed with primary progressive aphasia, it's where it's just really hard to get words out. Sometimes if it's a little bit too far progressed, it's difficult to tell what is the etiology. So try to catch people early, or at least in the middle, where we can actually get an accurate diagnosis to help us guide treatment as best as possible. All right, so treatments, the medication treatments. I just listed these, but again, these are all dependent on what is your actual diagnosis and what is the cause that your neurologist thinks. So memantine or Aricept are the typical ones for Alzheimer's dementia. The actual data for Aricept is that when patients were in the final stage of the disease before needing to go live in a skilled nursing memory care unit, patients who took Aricept were able to live at home 4 to 6 months longer. So that's technically what the proof showed. However, we extrapolate that information and we use it kind of for anybody else who has a cognitive impairment and see if that person benefits. And as long as they don't have bothersome side effects, if they have any perceived improvement, it's okay to stay on that. The primary progressive aphasia / frontotemporal dementia spectrum, I personally have found that memantine is helpful for my patients, helping them a little bit with their words and their communication skills. Aricept typically makes this condition a little worse in terms of the behavioral changes. So sometimes if you're not sure what someone has and you give them the Aricept, they get worse, then that tells you maybe it's not actual Alzheimer's dementia, maybe it's the frontotemporal dementia. But again, trial and error, a lot of this is in close observation. PD dementia or just PD cognitive changes. Rivastigmine is a medication that I typically use. Seroquel is also a general antipsychotic medication, but it's a very weak and gentle one for this age group for patients who have confusion, agitation, hallucinations, a harder time in the evenings or overnight. That one can be used as needed. Nuplazid is a relatively newish medication. I think it came out probably 4 or 5 years ago, maybe longer, for actual PD dementia, meaning hallucinations, and the typical PD dementia, again, sort of extrapolated to be used otherwise for dementia with Lewy body because they both look very similar. So it depends what a doctor labels you as, and keeping in mind that there is no proof for any of these conditions. There's no test that proves any of these with 100% certainty. PD psychosis. So PD psychosis is a lot more severe than PD dementia. PD psychosis means a rapid progression and severe cognitive changes, including hallucinations, delusions, paranoia, visual spatial deficits, and something that we call imposter syndrome, which can be quite scary. Imposter syndrome is when a patient believes that there is another version of a friend or family member. So they will say like, oh, my other husband came to get me. Where did he go? Or where is the other Mary? Or something like that, where they don't believe that the person is the real person. They believe they have been replaced by a body double. And that can be very, very scary to patients as well as caregivers. So I try to keep a close eye out for this. Clozaril is a very strong medication that can be used for psychosis. It has a very high side effect profile of causing abnormal blood counts, which can be deadly. So if this is used, that person has to get blood work drawn every week, basically. So it's my last ditch resort, really, for anybody who I can't get a hold of their symptoms with any of the other medications. And then the last one, dementia with Lewy body, which sometimes can look like PD dementia. It just makes a difference, like the timeline makes a difference. What started first? Was it Parkinson's disease movement physical symptoms, or was it cognitive symptoms that started first? And that helps you try to do your best to differentiate between these two. The treatment, mostly similar. So the rivastigmine, again, can help with the delusions, paranoia, and hallucinations and help improve that visuospatial awareness a little bit better. All right, then the other half of the treatment, however, is very important as well, is the supportive care treatment. So you cannot just give meds and kind of forget about it. You have to do a lot more aggressive treatments for any of the cognitive impairment issues. So after the formal cognitive testing, I typically offer patients cognitive rehabilitation, which is basically like physical therapy for your brain. It's performed usually by a speech therapist, but it can be like a social worker as well. You basically sit down with someone, pinpoint the areas of deficit that were gathered during the formal cognitive testing, and come up with strategies and behavioral modifications. So does that person have a reduced attention span and they need to write everything down on a list or have reminders? Does this person have visuospatial deficits and they may need some supportive care tools to make it easier to do things like brush their teeth or use a key or something like that? Physical and occupational therapy also important as well for, again, patients with that visuospatial awareness issue. Oh, sorry, I'm getting close to my time. So we do that, and then a social worker, sometimes we get a social worker involved if there are safety issues affecting the patient or caregiver safety, and if we think that someone needs to be living in a monitored care setting, and if it's no longer safe to be living at home. Okay, so we can do questions for a few minutes. Oops.
Okay, thank you, Dr. Cardone.
Sure, that was a brief overview. It could be hours and hours of lecture, but.
If anyone has questions, please, you can actually unmute yourself and ask it directly. Or type it in the chat if that's easier for you.
This was absolutely amazing, Dr. Cardone.
Thank you. Oh,
Can't believe I'm looking forward to number 2 and number 3.
Yes.
Yeah. Okay. So when a thyroid is removed and thyroid levels are maintained through Synthroid alone, is there any additional impact on cognition? Not typically, unless you had your thyroid removed due to cancer and then you needed chemotherapy or radiation. Yes, but if it's not that and you're just back to normal with medication, that's typically normal, and that's okay as long as the levels are monitored periodically.
I did have it removed due to cancer, so I did have the radiation.
Okay.
Regarding noctopia, can those occurrences and frequencies of getting up to use the restroom be impacted by, like, maybe someone who has a glass of water on their nightstand, or does that change it?
Yeah, not as drastic of the other issues, but yes, if a patient is really getting up to go to the bathroom all night, I do say, like, what's the last time you take a drink that day? If it's an issue, maybe stop liquids at 6 p.m. and observe if you feel less need to get up and go to the bathroom overnight. The other thing is like diuretics. So if patients take diuretics and then they say they get up to go to the bathroom all night, I make sure that they know to try to take their diuretics earlier in the day and don't take a diuretic right at bedtime, because then you'll have to get up and pee all night. When do the results of a cognitive test result in the ability to continue driving? So this is a very tough one. So my rule of thumb is if a patient is having hallucinations, they're seeing things that other people do not see, or they are not seeing things that other people you are supposed to see, or if they are seeing something and thinking it's something else, that's when I typically say it's time to stop driving, because that can cause an actual accident. Unless someone is in that obvious category, if they're in the gray area, that's a matter of judgment, and I typically ask for help for that. I usually ask people to have a driving evaluation, and the UPMC Occupational Therapy Department has an on-road driving and a driving evaluation program. So I kind of defer to them, because there's no right or wrong answer in this, unless you have episodes of passing out, episodes of seizure, or those hallucinations/illusions.
Looks like we might have time for one more question. If anyone has a last question, please go ahead.
If you use a CPAP machine, should you use it if you take a nap during the day?
Yeah, I actually tell people to, like, again, as much as you can use it is the best. So if you have apnea where you're not breathing while you're sleeping and you're taking a nap for like more than a half an hour, yeah, you should probably put your CPAP on for that.
Yeah.
Dr. Cardone, I've heard 150 minutes of cardiovascular exercise. You had mentioned a little bit less, the 135.
Oh, maybe 45, 50 minutes a day.
Okay, got it.
3 times.
I just
Yeah,
was
around
wondering.
that. Yeah, around that. Yeah,
Around
150
that.
seems about right. Yeah.
Okay, good goal.
Yeah.
As we conclude, do you mind sharing the area you'll be speaking about next month regarding cognition? If you
I
know.
think, yeah, probably PD dementia / dementia with Lewy body. That probably would take up about an hour of a lecture.
Okay.
Okay.
Well, thank you, Dr. Cardone. Thank you, everyone, for joining. And we will see you in February.
Thank you. Thank you, everyone. Have a good rest of the day. Take care.
Thank you. Bye, everybody.